So hi there, the aim of this brief video is to demonstrate and teach you the surgical cricothyroidotomy using the scalpel bougie technique. By the end of the video you should be able to describe the indications for the technique, to list the relevant equipment that you'll need, to describe the anatomy, and then finally to perform the surgical cricothyroidotomy using the scalpel bougie technique. To put this all into a bit of context, here at Queen's in the last 3 years we've needed to do surgical cricothyroidotomies on the following patients. Firstly, after routine induction of anaesthesia, which developed into a can't intubate, can't ventilate scenario. Remember, this is the final common pathway of the Difficult Airway Society guidelines. In major trauma following maxillofacial fractures, in which blood and secretions in the airway meant that aortic fibre optic intubation is impossible. And finally, after deep airway space infections, for example, dental abscesses, we've got a case series here at Queen's of 26 patients. 4 of those patients, the airway was attempted to be intubated while asleep, and 2 of those ended up being can't intubate, can't ventilate scenarios. Okay, surgical cricothyroidotomy, as I said, is a skill that can be performed by anaesthetists, surgeons and A&E doctors, and really anyone on the trauma team. Okay, so traditionally we've broken down emergency cricothyroidotomy into needle over cannula techniques and surgical techniques, and anaesthetists have been traditionally more favourable of doing needle over cannula techniques. However, we know from the recent NAP4 guidelines that only 37% of these were successful, whereas surgical cricothyroidotomy, over 90% of them were successful. Some people might advocate the use of surgical tracheostomy for this scenario. However, that requires significant surgical skill, equipment, and is time consuming. And it's unlikely you'll have these available in an emergency situation. First of all is do a silent run through of the procedure, and then we'll go through it bit by bit, breaking up into small steps. Okay. Okay, so squeegee out, cuff up. Thanks. Okay, so looking at the equipment you'll need, a size 6 endotracheal tube, a number 10 scalpel, and if you notice that these are exactly the same size, same diameter, a bougie, an emergency cricothyroidotomy set from the difficult airway trolley, which contains a sponge holder, some scissors, a needle holder, and a tracheal hook. A means of ventilating, in the first instance this will be a self-inflating bag, a syringe to blow the balloon up. So finally you'll need a capnograph to confirm end-tidal carbon dioxide. So let's look at the anatomy. To find the cricothyroid membrane, put your finger on the chin and the midline, move down the neck. The first structure you'll find is thyroid cartilage, and the second structure will be the cricoid ring. In between the two is the cricothyroid membrane. In a trauma scenario, or if you're really worried, then you should be marking this prior to induction anaesthesia. Because in a can't intubate, can't ventilate scenario, you'll be under a loss of pressure. Okay, so let's run through that with some top tips and some commentary. Okay, I'm going to approach the patient from the right-hand side with the head here and the feet down here because I'm right-handed. But equally, you could approach from the left-hand side if you're left-handed. But beware, in a busy resus department, you might not have a choice. Okay, if in a real-life situation, in the likely event that the patient's awake, then you'll be using local anaesthetic. And obviously, if you've got time, you'll be using full sterile precautions. So take the scalpel in my right hand. I've obviously pre-marked the membrane, do a stab incision and then rotate the blade through 90 degrees. Take the scalpel perpendicular to the neck and then rotate it and remove the scalpel. The bougie should hold up and you should feel tracheal rings. Just as a normal intubation, the bevel of the endotracheal tube needs to be facing upwards, otherwise this can happen and it won't railroad over. Obviously there'll be a lot of blood at this point, so at this point you might want to use a tracheal hook, which comes in from the side, to rotate it, and then you might need to ask your assistant to pull some traction and then advance your tube. Blow the balloon up and then confirm your position clinically and with a capnograph. Okay, so the tube's in place, we need to secure it, and we'll do that with a 2-0 silk suture. So here's the endotracheal tube sutured in place, just like you do with a chest drain with a 2-0 silk suture. So in the obese patient, you may not be able to palpate the landmarks. So in this scenario, you need to do a large midline incision through the skin and subcutaneous tissue, and then palpate the landmarks of the thyroid and the cricoid cartilage, and then proceed as we've demonstrated before. Okay, so now it's your turn. We've got the bench trainer here for you to have a go on. And in summary, we have described the indications for performing a surgical cricothyroidotomy. We've described the relevant anatomy, listed the equipment you need, and finally we've demonstrated it on a bench model. As a guide, you should be aiming to do this procedure in under 40 seconds, and really you need to be practicing this every 6 months to keep your skills up.